Okay, good evening, everybody. And I want to give a hat tip to you for coming out tonight. Thank you so much for coming. We really appreciate it. For those of you who don't know me, I'm Rhoda Shermer, and I'm welcoming you on behalf of the Network for Responsible Public Policy. And I want to thank our sponsors who help make these programs possible, and that is the League of Women Voters of Fair Lawn and the League of Women Voters of Northern Valley. So hat tip to them too. And thank you all for donating tonight. That helps a great deal. So tonight's program is very challenging. I can remember this fact that when it's about almost 10 years ago that NFRPP first launched itself, and that was to try to combat misleading information. And the first program that we ran was, guess what? The Affordable Care Act. So that's been contentious all these years, and here we are 10 years later, and we're still talking health care coverage. So I'm going to introduce our two people tonight. One is our speaker, Joel Cantor, and the other is journalist John Tozzi, who will be interviewing Dr. Cantor after his presentation, and then we'll open it up for your good questions. So let me introduce you to Professor Cantor. You're getting the summary version of his bio. He is a distinguished professor of public policy and founding director of the Center for State Health Policy at Rutgers University. He is a widely published scholar on the effects of healthcare insurance regulatory policy in New Jersey and nationally under the Affordable Care Act. Dr. Cantor also leads research on innovative health service delivery and policy strategies for the Medicaid programs. Professor Cantor also serves as an advisor on health policy matters to the New Jersey State government and serves on the New Jersey State Health Benefit Program Quality and Value Task Force. Recipient of the Rutgers University President's Award for Research in Service to New Jersey, Dr. Cantor is an elected member of the National Academy of Social Insurance, and Professor Cantor earned his doctorate in health policy and management from the Johns Hopkins University of Public Health. So following Dr. Cantor's presentation, John Tozzi will interview him, and John is a reporter for Bloomberg News, covering health insurance, hospitals, medical services, and health policy. He graduated from Boston University in 2005, and at Columbia University, he was named a Knight Fellow and graduated with a Master's of Science in Journalism with extensive study at Columbia Business School. He began his journalism career with the Times Ledger chain and has been with Business Week magazine since 2008, and he's brought a few copies of the Business Week magazine. They're on the table outside, and you can help yourself to that and help yourself to any of the other handouts that are out there. And I want to let you know in advance that on June 6th, we'll be holding a program here that will have 4 speakers who will be analyzing the ideas in the Green New Deal. So you might want to put that on your calendar. So without further delay, Dr. Cantor. Please welcome Dr. Cantor.
Thank you. Rhoda reminded me that the last time I spoke before this group, I got lost and was a half hour late, so it's already better than last time. So thanks so much for having me. It's kind of a slow news day out there, so at least we'll have an interesting topic to talk about, I think. So I have just a little bit of introductory talk, and you know, public policy professors can't actually talk without slides. It's like lawyers writing without footnotes. So I have just a few slides. So, today's topic is achieving universal coverage. Is Medicare for all the answer? So I think we have to start with the question, what are we trying to achieve? Now, of course, the title says universal coverage, so of course that's one of the goals. But I would argue that the proponents of Medicare for All and critics of the US healthcare system in general have other goals they want to achieve with broad health reforms. I'll put those on the table too. Achieving affordability and equity, so affordable insurance and affordable health care and the equitable distribution of course, universal coverage, but equitable distribution of health services as well. Efficiency or cost control, and I'll show you just a little bit of data. Students every year do an evaluation, an anonymous evaluation of the professor, and a couple of years ago, I had a master's student sort of accuse me of hosing the class with data. I promise not to do that. I do tend to use a lot of data. I'll just show you a little tonight. So finally, one that I would put on the table, I don't know if everybody does, is the question of feasibility. Is any kind of reform we want to do politically feasible, fiscally feasible, technically feasible? So I will try to touch on each of these. Let's start with the coverage question, and then we'll go from there. So, so almost by definition, Medicare for All would achieve universal coverage, or at least close to it. There would be a few sticky issues around publicly financed coverage for certain classes of immigrants, undocumented immigrants, new legally present immigrants, so a huge myriad of phase-in issues and transitional issues. But putting that aside, of course, Medicare for All is the answer if the question is, can we cover everyone? He designed a program that covers everyone. This slide shows that about 10% of the US population, I guess it's the white slice or gray, I'm not sure how it shows up there, has no insurance. So that's the gap we're trying to close. It's a little under 10% now. I'll come back to this, but it's important to note that the biggest slice, the big blue slice up there, about half of the population has coverage from an employer, their own employer, a spouse's employer, a retirement health plan among them. And then there's Medicaid for low-income folks and certain disabled folks, and Medicare for older folks and other folks with certain disabilities. So the gray slice, the other private, includes what most people think of when we talk about Obamacare, right? So that's people who don't have access to the big public programs, Medicare, Medicaid, and people who don't have access to employer-sponsored coverage can go on healthcare.gov, which these days works pretty well, and get coverage, and if their income is low enough, they get subsidies for that coverage. So that's the slice that actually, since the implementation of the ACA, and I'll show you this in a little bit, has grown. But it's still only a fraction of the population. So all this hoopla and controversy and political mudslinging is about that 10% of the population. Not entirely, that's an exaggeration, but that's the crux of it. So this is the trend line in the share of the population, the percent of adults without health insurance in the US. So you can see the trend before, let's see, about 2014 was upward, and every year 1 million or 2 million more people would be uninsured, largely because the cost of coverage kept rising, employers would drop it, people wouldn't take it. And then the line drops precipitously as the ACA is phased in. So one thing I don't like about this slide, it's great because it has all the dates on there, but data purists would say you shouldn't end the scale at 10%, it should go to 0. So this kind of exaggerates the depth of the plunge, just being the data purist that I am. But you can see the uninsured rate was almost cut in half. And then President Trump is elected, and it starts creeping up again. And we can go into this in Q&A if you're interested, but there's a long list of things the Trump administration has done and Congress to some extent to undermine the ACA. It's still the law of the land. Not everyone knows that. At least as of this month, it's still the law of the land. Okay, so that's coverage. So there is a gap to close, and the debate is, should we move to a national Medicare for all kind of program or some other mechanism to close that gap? But before we go on, discuss that more, let's turn to sort of the next purpose of Medicare for all, and that's the affordability and equity question. So let me unpack this a little bit, talk about affordability. Oops, don't do that. Talk about affordability. I have no data here, but talk about affordability a little bit. So if we were just to take Medicare, today's Medicare program, and make everybody eligible, I think most analysts would argue that we would not solve the affordability problem. It has no coverage for certain important services. Those of you who are on Medicare know this. Vision, dental, no long-term care services, that's covered under Medicaid with a deductible of everything you own. Also importantly, no out-of-pocket maximum cap. So the ACA, Obamacare, put in place a rule that virtually every kind of private insurance has to have a maximum out-of-pocket exposure. So $5,000, $7,000, depending on your plan. After that, you pay nothing. Medicare doesn't have that, so there's pretty much infinite exposure for people with catastrophic illness. About a third of the Medicare population buys a private plan with their Medicare dollars, so-called Medicare Advantage plan. Many of those plans close a lot of those gaps, often for extra premium, or the beneficiary is sort of giving up provider choice, closed HMO kind of network. Of the remaining people on traditional Medicare, about 80% gets some kind of supplemental coverage. A third of those people, almost a third of those people, are covered by employer-provided supplement, retirement plan. Another 30% or so by a so-called Medigap plan, a private plan that you can go on the marketplace and buy to fill in the gaps in Medicare. And 22% of Medicare beneficiaries also have Medicaid. Those are the lowest income Medicare beneficiaries. As I said, there is no long-term care coverage in Medicare, even with any of these supplements, except Medicaid. The program pays for nursing home and some home care. About 5% of people also buy a private long-term care policy, not many. So when you look at the proposals for Medicare for all, Bernie Sanders and the House proposal and so on, they go way beyond what Medicare is. So it's almost a misnomer to say all we have to do is expand Medicare and we solve our problems. They're completely redesigning the benefit package, expanding it, much less cost sharing, much more public financing than the Medicare program as we know it today. So turning to the question of equitability, in there I want to talk a little bit about how we pay for Medicare. Do we pay for it in a fair and equitable way? Well, it's certainly, and this was actually my dissertation from like 30 years ago, but the public financing of Medicare is by far more progressive in the taxation sense than private insurance. So if we went for private insurance for all, even with subsidies, the way Medicare is financed would be paid more by higher income people, less by lower income people. But it is hardly as progressive as many of the Medicare for all advocates would want. So Medicare Part A, the hospital part, is funded with a payroll tax, which is not very progressive. It's essentially a flat tax with a cutoff when your income's high enough. The ACA expanded the taxation for high income people a little bit, but it's still not a progressive tax. Parts B and D, so the doctor part and the prescription drug coverage requires premiums for most people. And those are not progressive. There are some subsidies built in for low-income folks there, which helps. It's a very complex financing system, but arguably it doesn't do as much to achieve equity in financing as advocates would like. So the Medicare for All proposals change that too and make it a much more of a tax finance system drawing on the general federal income tax, possibly raising some taxes and other taxes on high income people, which would make it much more progressive than the current Medicare program is. So in sum, affordability and equitability, well, the current program, not so much, at least not for everybody, but the proposals seek to change that. Really raising the question of whether it's really Medicare for all or we're just branding a nationalized single-payer system. So then the question of efficiency or cost containment. To economists, efficiency means very specific things, but I use the term generally in the kind of colloquial way we all would. Are we getting good value for the dollar? I would argue that Medicare does a much better job at this than private health insurance. It spends, once you adjust for how sick people are and their age and so forth, the spending per person is lower than it would be if it were a private system. It achieves that largely by paying providers less money. So lower prices to providers, lower payment rates to hospitals, doctors, and other kinds of providers. Medicare has also been the main source for experimentation in incentives for lower cost, more efficient care. Accountable care organizations, bundled payments, the DRG system, the way we pay hospitals. I won't go into this detail because I want everyone to stay awake. But in fact, that's where most of the payment reform experimentation has gone on in this country, and the private sector tends to follow what Medicare does, not the other way around. So there's a lot to be said for Medicare on that side. The one big exception is Part D, which uses a market competition approach, competing plans that then negotiate prices with providers. The evidence on this is that it works pretty well, except for those drugs that have no good substitutes. So the new patented medicines, especially breakthrough medicines, medicines that do people a lot of good, may save lives, dramatically improve quality of life, so they're absolutely medically necessary, yet there are no substitutes. And that's where a lot of the controversy you hear about in drug pricing is centered on, and Medicare Part D does not do a good job holding those costs down. Bottom line here, it's likely that the Medicare for All proposals or any certain national single payer kind of approach would reduce spending a great deal, but not perfectly. The way Medicare pays providers, doctors in particular, creates a really strong bias in our healthcare system away from primary care and other so-called cognitively intensive, sorry for the jargon, cognitively intensive specialties, think psychiatry, talk-intensive specialties, toward procedure-intensive specialties, surgery, diagnosis, using the latest diagnostic technology, and so forth. And this is built in structurally to the Medicare program. And as I said, the private sector follows Medicare on its innovations. It also follows Medicare on the relative prices between the cognitively intensive primary care and so forth and the high-tech procedure-oriented stuff. This is unique in the world. how does this happen? Well, Medicare essentially delegates to a committee convened by the American Medical Association, and this is deep in the weeds, called the Relative Value Update Committee, a name intended to be as opaque as possible. It's a large committee with representatives from most of the medical specialties, including primary care. But when you look at the membership, it's really heavily skewed towards specialty care. So I have to admit I haven't read every page of the Medicare for All legislation. But I have not seen how this problem is addressed, and it's a deeply rooted political stranglehold. So if we move to a national Medicare program with this kind of structural thing in place, we wouldn't solve the efficiency problem because we'd be running too many tests, doing too many interventionist things, and not talking to people enough. We wouldn't have enough primary care providers like is the case today. So as I said, I don't think the Medicare for All proposals really take on sort of every little corner of the structural problems that are institutionalized because of the way Medicare does things. So while we're on the subject of cost, so this chart shows the trend in healthcare spending per capita in a whole array of countries that are demographically and economically similar to the US. And as you can see, we stand alone. This is not the kind of American exceptionalism that you want to see, where we spend about twice as much as the average of these other countries, 20% more than any other country on healthcare per capita. The line for the US is rising faster than the other lines, so we have less cost control. And it's largely because of the structural things that I talked about. Okay, let me just add one or two other things here. The research that addresses the question of why are we so much higher and why are we rising so much faster, easily half of the reason is just higher prices. The sort of next runner-up reason is that we use more of this high-tech, high-intervention stuff with the bias that we have in our system. We also, a little bit of it has to do with higher rates of obesity and chronic diseases compared to some of the other countries, but those first two are the biggies, prices and just our rapid adoption of new technologies, even when they aren't a whole lot better than the old technologies, yet they cost a lot more. So would Medicare for All solve this? Well, it might solve the price problem by cranking down on what we pay providers now, but I don't think it solves the upward trend problem in our high-tech bias, in the kinds of structural things I talked about. Okay. All right. So before turning to the feasibility question, let me just kind of summarize where I think I'm coming out now. So Medicare for All would achieve universal coverage by definition, or something close to it, with a couple of sticky issues that I mentioned. Medicare has lots of gaps, but those drafting the legislation seem to be solving that problem by spending a lot more on federal general revenue and filling the gaps. The current Medicare financing system is not nearly as progressive as the advocates would like, so they changed that too. And Medicare does a better job than the private sector of containing costs, mainly by paying providers less. But it has created this structural bias that, as I read the current proposals, just don't go away under a Medicare for All strategy. So all of this is to say that the real attraction of Medicare for All sounds so simple. but it's not. It's really quite complex. As complex or more complex than what Obama did with the Affordable Care Act, which is, the incredibly complex set of rules. All right, so let's turn to this question of feasibility. Let me start with a couple more numbers. So healthcare in the US is just shy of 18% of our gross domestic product. It's the 18% of the US economy, nearly $1 in $5 of economic activity in this country. As I said, and you saw in the chart earlier, vastly more than other countries. So that's a huge part of the economy to disrupt, and Medicare for All or anything like it would be enormously disruptive to that. By the time we did it, it would be $1 in $5 of the economy. To meet its full promise, Medicare for All would have to really turn the thumb screws on payments to providers. It would reduce incomes for hospitals. It would reduce incomes for physicians, especially specialty physicians, other healthcare workers, drug makers, device manufacturers, and so forth. These are not political constituencies to be trifled with. Yet, in order to achieve the promise of Medicare for All, these oxes would need to be gored, at least over time. One example, it would eliminate or significantly reduce the role of private health insurance. That's part of its purpose. Well, the private health insurance industry employs about 500,000 people, and all over the world, or they're all over the country rather, and lots of congressional districts. Again, big impact as we make the transition. Medicare for All proposals would mobilize one of the most powerful lobbying campaigns I think we've ever seen in this country. It would make the fight over Obamacare look quaint in comparison. So let me turn a little bit now to a little more data, and then I'll just wrap up with a few comments about if not Medicare for All, then what? I'm not going to satisfy our curiosity about all those, but it'll be a conversation starter. Rhoda mentioned the controversy over Obamacare. This is the trend in people who favor, with favorable and unfavorable opinions about the ACA, the Affordable Care Act, aka Obamacare. It's been pretty locked in at 40-40 for a long time. When things are going badly in the implementation of the ACA, like when healthcare.gov was imploding in the early implementation days, opposition spiked. When it's going reasonably well, it's kind of neck and neck. But then Donald Trump gets elected and the lines cross and stay crossed. Donald Trump is the single biggest force making Obamacare popular. And this is true in any kind of large-scale systemic reform. People fear the unknown. During the ACA debate, very early in the debate, when everybody could kind of fantasize about the reforms and what they would do, it was pretty popular. And then as the details became clear, and remember you can keep your plan if you like it, didn't work out quite that way, and there's a lot of change and pain, and there's always winners and losers, and there's always uncertainty and fear, and so any change like this is going to engender opposition until it becomes institutionalized. And this is the proponents of the Affordable Care Act have predicted this. Didn't come as soon as they wanted, but as soon as it's institutionalized, people fear losing something. And now we see the popularity rising, as you can see here. The most interesting thing on this chart to me is that little gray line at the bottom, which is 15 or 20% of people don't know. Suddenly, almost everybody knows where they stand on this. And so there's been a lot of folks saying, don't know, we're not answering the question. and that has dropped. Now people have an opinion. So, of course, the ACA, opinion about the ACA is it has a deep partisan divide. Republicans, those who approve of President Trump, the vast majority of them have an unfavorable view. Democrats have a vast majority, 3/4 or so, have a favorable view. Independents, right in between, they're the most likely to say, I don't know, as well. They tend to be not as engaged in the issues. Let's turn to ideas like Medicare for All. So this is a long-term trend, well, long-term since the late 90s, trend in opinion about creating a national health plan in which all Americans would get insurance from a single government plan. And it's been trending up modestly, so there's some support for it in general terms. Here's the partisan divide on this question, and it's the same thing that we saw earlier. Democrats like it, Republicans don't like it, independents are split. This is interesting. So this shows the trend 2006, 2008, 2019 in support for a government program that covers everybody. And throughout, the Democrats like it in the 90% range in response to this question. But as you look over time, look at the Republican set of bars. 72% were attracted to the idea in 2006. Now it's 40%. Why is that? Well, it's suddenly become a partisan issue and not a policy issue anymore. So this is, healthcare is sort of hopelessly mired in our deep partisan divide in this country, and that's what this chart shows. Interesting, the public, this shows how people sort of change their views toward Medicare for All when asked in the surveys to respond to things the law of Medicare for All program might do. So start at the bottom. It would guarantee health insurance as a right for all Americans. 71% favor the idea. 27% oppose it. It would eliminate private health insurance premiums and reduce out-of-pocket costs. Almost similar levels of favorability. It would eliminate private health insurance companies, and it flips. I don't know anyone who, wants to hug their private health insurance card, or think when they have to deal with their insurance company that they like it. They have in ratings of confidence in various industries, it's near the bottom. It's above Congress, but not by that much. But people don't. This is the fear factor. Doing away with private health insurance flips support for Medicare for All to a majority oppose. Require most Americans to pay more taxes. Well, you could say, okay, if you're a supporter of Medicare for All, well, let's not require most Americans, let's tax the rich. Well, okay, that may solve that. Threaten the current Medicare program. Well, you could argue, well, it wouldn't. But you bet that, in fact, this even happened during the Affordable Care Act debate, that particularly seniors love Medicare, and they fear that any change to the American health insurance system would somehow undermine Medicare. And that fear is played on by the opponents. Think back to the ads during the ACA debate. Older people saying, oh, I'm worried about keep the government out of my Medicare. So even if it's not true, the messaging would be strong and it would drive opposition to Medicare for All. And then last, of course, the biggest fear is that it would lead to delays in people getting the tests and treatments they need, and then you have a very large majority opposing it. And there's data from Canada, which has something like Medicare for All. Their waiting times are a little longer for higher tech procedures, enough to scare people. So right now, before the debate is really underway, when people can still think of Medicare for all in the way, frame it, the way they want to, support's pretty high, at least among Democrats. But I would argue that as a serious political debate were to get underway, these arguments would gain traction, and we would see the fear factor grow and voter support decline. Okay. So this is the same slide I had earlier, and this is just to underscore how important that private insurance fear factor is. So 156 million people get their insurance from an employer. Most of them actually like it, or at least it's the devil they know. And they're worried about the devil they don't know. For people in large businesses, you got a problem, you go to the HR office, they troubleshoot it for you. And then the alternative is to call Medicare and be on hold, at least in people's minds. So one other interesting thing as we sort of pivot to, if not Medicare for all, then what, is that we see more support for incremental moves that might expand a Medicare-like platform for some, but not make it mandatory for all. And that's in essence what the basic premise behind the Affordable Care Act was, as much as it doesn't seem that way when we look at it in retrospect. Its guiding principle was leave the status quo in place when it works pretty well and fill the gaps. And that's still kind of a politically popular thing. So look at the two different, so the dark blue is a national health plan, Medicare for all, everybody would get a government program. The second, a national government administered health plan similar to Medicare that would be open to anyone, but it would allow people to keep the coverage they have if they prefer it. And there you get almost half of Republicans supporting the idea, and even more Democrats supporting it than support Medicare for all. So incrementalism, Americans are incrementalists. And so I think that this slide illustrates that. So just a little bit more data here. So here's a couple of more incremental proposals. The first one, allowing people ages 50 to 64 to buy into Medicare. So moving the age lower, so those of us who are on the precipice can jump in earlier if we want to, and that gets very high support, majority support, no matter what one's political party preference is. The second one, allowing people who don't get health insurance at work to buy health insurance through their state Medicaid program. Those are the programs for low-income people, and that gets equally high support. So these incrementalist ideas are very popular. I would argue they're technically complex, but that gives people like me full-time jobs, so it's a good thing. Okay. Here's, I think this is my last data slide. If not, I apologize. So how important is this in the election? Voters say candidates' stance on national health plan is important, but few say it is the most important factor in 2018. This was a midterm oriented thing. So the dark blue is those that say it's the single most important factor, a little bit more for Democrats than others. Very important, but not the most important. And for half or more, it is not a key factor. So is this going to, I think what this is predicting is that after the primary, we're going to hear a lot less about healthcare and more about other issues. But we'll see. Oh, no, not the last data slide. Democrats, this is just Democrats divided on what Congress ought to focus on, fixing the ACA or improving the ACA or passing Medicare for all, split right down the middle. So, all right, that was my last data slide. So let me just talk for a minute, and I'll close with this, and then we'll get grilled by the media. You ready? And there are folks like Krugman and others have written a lot about this. that, remember that slide I showed earlier about the cost trend in every European country or Western democracy had lower costs? And if I were really hosing you with data, I would have showed that their outcomes are as good or better than ours. They certainly cover all their people, and we don't. The quality is excellent in those places, at least as good as here, in some ways better. And they do it at a lower cost. So the question is, well, how do they do it, and are there any examples for us? So, of course, there's the way the UK goes, which is a government-owned system. It's like VA for all. By the way, the veterans really like the VA system, but this one doesn't, not so much. Yeah, okay. Well, in polls they do. But if the polling data I showed you earlier asked, should the government own and employ all the healthcare resources, and you go to a government-owned clinic, people would hate it. So that's not going to happen in this country. That's the UK. They like it mostly. Another example is the Netherlands, which is a private system in some ways much like ours, with a much higher level of regulation and government financing. The government financing makes the financing more progressive, and the regulation really turns the insurance industry into sort of a commodity where they're doing a standardized service, and you're not going to pick Blue Cross over Aetna because one has a better reputation. They're doing the same thing because they're doing what the government tells them to do. They cover everybody, and it does so rather efficiently. France has a mixed public and private system, and virtually every other country has at least a little bit of private insurance, sometimes to supplement beyond what the government program does, sometimes as a separate system. No other country comes close to the amount of private insurance that we have. But there's all stripes of these different kinds of national health programs. The ingredients of those, virtually every other one, is government financing and highly regulated or government-run insurance system. And many of them, I would argue mostly the majority, the delivery system, the doctors, the hospitals are primarily, with the exception of the UK, primarily private, paid for by either public programs or highly regulated private programs. So that's what I have. I think I've covered this. Just quickly, Medicare for all would require significant changes. We've been through that. Deeply entrenched interests, dislodging 156 million people from their employer-sponsored coverage, perhaps phased in over time. Public opinion favors incrementalism, and international experience suggests there's many roads to the goals I had on that first slide. So people often ask me, if it were up to me, what would I do? And I would say if this were 1932 and I was designing something from scratch, it would look like Medicare for all, or at least some version of it. But I don't think we can go back. So I think we have to look at these incremental options. So that's what I have.
So, Joel, I think the place I'd like to start is asking about why we're even having this conversation right now. Because in 2013, when Bernie Sanders introduced a Medicare for All proposal, it had 0 co-sponsors in the Senate. And when he did it again 2 weeks ago or so, it had 14 Democratic senators co-sponsoring it, including Kamala Harris, Cory Booker, Kirsten Gillibrand, Elizabeth Warren. So 5 of the 6 Democratic senators who are running for president are officially sponsors or co-sponsors of a Medicare for All proposal. So what in your view has changed either in the healthcare industry or in the political environment in the past 5 or 6 years to make that happen?
Well, I think on the healthcare side, the problems we face and the solutions that the ACA brought, well, those are 2 different things. The problems we face continue to sort of worsen. So costs keep going up, at least since the last presidential election. The fear that we're going to lose our coverage, and some people are losing their coverage, has become more real. We now know what problems the ACA has solved and what problems it hasn't solved. So I think regardless, there would be a debate about what's next. But I don't think that's the strong force. I think the strong force is what's going on in American politics these days. And with polarization for a variety of reasons, from gerrymandering to people migrating to live in places with people like them, and the strong voice from the wings of both parties. I would argue it's stronger on the right, but the left has a stronger voice than it did before. The Bernie wing of the party is stronger. So I think what we're observing is people jockeying for position in the Democratic primary. And as I said earlier, I think that well, of course, it depends who wins, but that I think this becomes less of a loud issue after we have a candidate on both sides.
Just to kind of underscore how real this discussion is, I'll share that I was covering United Healthcare's earnings report Tuesday morning. They had an excellent first quarter. They reported profits above expectations. They raised their outlook for the year. Normally what happens after that is that a company's stock goes up. And on Tuesday, the CEO made some comments about Medicare for All and how disruptive it would be to the healthcare system. And all day, the shares of United Health Group and its peers, other health insurers, and publicly traded hospital companies tanked. And they kept tanking on Wednesday. I forget which day it was, but one day there was a $28 billion market cap loss because people were getting out of these stocks. So that's not to say that investors think Medicare for All is going to become law, but it's a sign of how it sort of injected some instability into the political environment and certainly into the markets. So there's no question that what we're talking about is this is not a abstract idea, that this is something people are taking as a serious, if slim possibility, but something that could really become law.
I think you're absolutely right. I think it signals to investors and others that there is a willingness to use the strong arm of government to get the healthcare system into shape. And that may be just stronger regulation. I don't know what stocks did with the ACA, you can probably tell us, but it did a couple of things. It much more strongly regulated insurance. So, for example, it capped the amount that they can keep. So it required a certain level of dollars to go out in medical benefits, and if they make a profit above that 15 or 20% level, then they have to give refunds to the policyholders. I think that would drive stock prices down, but on the other hand, it enfranchised 10 million people and expanded the scope of the industry, so that certainly helps boost the industry. So there's another 8 or 10 million people to go. But after that, I think government action is going to be to more tightly regulate, and as I said, kind of turn them into commodities over time, because that's the only way that the system can become more efficient.
So one thing I think that's worth unpacking here is, I think people tend to think of this as a kind of binary, Medicare is government insurance and, private insurance is private insurance, and you're either in favor of a free market system or you're in favor of a government-run system. But the system we have today, both in the kind of employer market and in the public programs, Medicare and Medicaid, are highly entwined between the private sector and the public sector. As you pointed out in your presentation, about a third of Medicare enrollees get their coverage essentially filtered through a private company like Humana or Anthem or United or other smaller plans in the Medicare Advantage program. Same for Medicaid. Many states have managed care in Medicaid. And on the employer side, where I get my health insurance, that is massively subsidized by tax breaks for employer-provided health insurance. They're not taxed as compensation. They have to conform with regulations that the government sets, right? Mm-hmm. So it's not this kind of, are you for government healthcare? Are you for free market healthcare? There's a lot of intermingling in what we're.
That's right. And I think Medicare Part D is a very good example. It relies on essentially competitive bidding in a sense, competing private plans, which for most drugs works pretty well. I would argue it imposes costs on beneficiaries and hassle and headache, and your formulary changes, and you have to go back to school once a year during open enrollment. I think that's a real burden. I help my mother with that. And here I am, a health policy expert. My sister is a geriatric social worker, and it takes like the whole family to figure out what plan to buy for my mother. But multiply that times 30 million, and you have a problem. But in terms of cost and efficiency, it's okay if the government were willing to step up and regulate the prices of the monopoly drugs. It would go a long way. So it's really a question of how to blend the market forces with government regulation. I would argue that government regulations aren't quite strong enough, but you're right, I think it's a question of how you blend them.
And so, I want to elaborate on that a little bit, because I think, one of the questions, there's a sort of philosophical divide between, do you think there should be a market for healthcare? Is it something that should be bought and sold in the private marketplace, or do you think it should be, a fully government-provided service? So can you kind of talk about some of the arguments on each side? Like, what are the roles of market forces, incentives in healthcare markets? How do they function in the United States, and where do they, as you said, with sort of monopoly drugs, where do they sort of not play their function?
Well, I think you have to ask the question: what does government do well, and what does the private sector do well? And on things like driving innovation in how to use data analytics to improve population health. I want to see the private companies have a huge role there. That's not something government does terribly well. When it comes to questions of, well, how do we equitably finance this so that even low-income people can afford what care they need, and people aren't paying outrageous shares of their income for their health insurance and care. Only government can redistribute, so that's clearly a government role. Then there's a lot of gray area in between. Even in traditional Medicare, they use something called fiscal intermediaries, which are private companies they hire by competitive bid to process the claims. They're essentially data processing companies. They will always use companies like that. And I think government does a reasonably good job of that kind of competitive bidding. We probably need to do more of it. If that kind of competition is not adequately structured, it leads to extraordinarily high administrative burdens. There are more people in hospitals in this country processing bills and then doctors' offices, getting pre-certs, certification, and collecting from insurance companies and appealing coverage decisions than in any other country on earth. And that's because we allow just so much variation in the way the private sector operates. So I think a lot of it boils down to structuring things better. with a stronger government hand to sort of tame the private sector to do what it does well, instead of sort of competing on hassle factor and cherry picking the low risk people and the kinds of things that it directs its energy to in less structured markets.
So I'll take a minute to ask the audience, how many people here have insurance through Medicare? Okay, I'm gonna eyeball it and say a majority. How many have private insurance? Anyone uninsured or other source? And for the people in this room, how many people would support a Medicare for all proposal? Okay, so not insignificant. And oppose? Okay.
They'll split right down the middle.
Yeah, it looks about like your
Anyone
side.
changed their mind since I started?
And
I have a question because I'm confused about the objections to Medicare for all. You said it would be disruptive and that it would eliminate the private insurance industry. And I've been on Medicare for close to a decade. And when I first had it, I was working and I also had private insurance, which was primary. But I kept my private insurance even though I had Medicare. And now I have a supplemental policy, which is private insurance, which I pay less than $100 a month, but it gives me complete coverage and a limit on my total expenses. So if Medicare for all is Medicare like I've experienced Medicare, there will be private insurance.
well, I think it's a good point that, to some extent, we don't actually know what we're talking about when we say Medicare for all.
yourself.
That's right. I don't know. I don't know what we're talking about when
I agree.
we say Medicare for all. Because, there are a couple of bills that have been filed. They are, I think, they have not gone through the process of what happens in Washington when you produce legislation that you actually intend to become law, right? These are bills that are out there for people to talk about, campaign on. Certainly in the current Congress, nothing like the House bill or Bernie Sanders' Senate Medicare for All bill is going to go very far. So, and those two proposals are different, and so we're talking about an idea here, and I think, when you say, you're on Medicare and it looks a lot like private insurance, I think there are a lot of people in the insurance industry who would love to have something like Medicare Advantage for all, right? Where the government is saying, we're going to have a universal coverage financed by public subsidies, but essentially administered through private entities that will compete on some, sort of within some kind of wiggle room for differentiating products.
Yeah, one thing I didn't get into in the talk is that something like Medicare Advantage for all is potentially appealing, especially if you allow people to use, say it's sort of a government voucher, and you could, help pay for your employer plan, or use it for Obamacare plan, and I think that would be feasible and really popular, but it would require a huge amount of new government revenue, which of course will be another sticking point. And I think people don't believe that economists will make the argument that the health insurance costs paid by your employer actually are paid by the employee, because if they didn't have to pay the $6,000-7,000 a year premium for a family, then people would get higher wages.
Right. To the employer, it's all just compensation.
It's
expense,
all just
whether it's going
compensation, right?
healthcare.
With the tax advantage you mentioned, so that tends us to skew it toward more health insurance, less cash. But if that goes away, and the government puts up the money for the health insurance, this is some risky. It's like a lawyer asking a question they don't know the answer to. But how many folks believe that the employers in this country would give everybody a raise of several $1,000s if the government financed? Right. So nobody here is an economist.
Well, right. It depends on. I mean, in this labor market, it might actually happen because there is
Right.
a tight labor market.
It's very much labor market driven, and I would say in this labor market, wages would go up. In a weak labor market, I would say it would there'd be more stock buybacks.
Yeah. Another question from the audience.
Yeah. To what extent do you feel that the cost of medical education and getting drugs developed to market are sort of root causes of some of these problems?
Not as much as I think those involved in those two sectors would lead you to believe. Let me add one other: medical malpractice. Also, if you listen to the rhetoric, those are the major drivers of our healthcare cost problems. Pharmaceutical companies, and this is clearly supported by evidence, will charge high prices because they can, and then they will argue they need it for investment. Now, at some point, if they're losing money or if their profits weaken, they'll have less money for investment. But they're going to invest in things where they see a return. So I don't, I think it's rhetoric.
And medical education?
Now, medical education, certainly medical education financing in this country is a problem. It's the amount of debt young physicians take on is obscene, but I don't think it's driving the costs in our system. The largest financer of medical education in this country is the Medicare program. So it pays supplements to primarily hospitals. This is for graduate medical education. Once they have their MD, then you have to do the residency and so forth, and that's largely Medicare finance. So it's, I don't think that's a driver. Likewise, the medical malpractice system is a horrible system that works poorly for everyone involved, but it's a tiny fraction of the cost problem, tiny fraction.
I think one thing that may be worth doing, just to outline it, the total spending on healthcare in the United States last year was about $3.5 trillion. So when you hear 18% of the GDP, that's the number that you're talking about, 35 trillion. Now of that,
3.5.
Excuse me, 3.5, I'm sorry, missed a decimal point, sorry, 3.5 trillion. Of that, the net cost of health insurance, so basically what insurance companies take for their profits and their overhead and their operating costs that doesn't get paid out to medical providers and drug makers, is $230 billion. It's about 7% of the total health spend in the US. So you could wipe out the entire overhead and profit of the private insurance industry in the US and still not really make a significant dent on those numbers you had up about how out of line our health spending is compared to other nations.
Well, and I would argue you can't squeeze it all out because they're serving functions that would have to be replaced, even if they were government functions.
But the bulk of that spending, about half of it, goes to hospitals and physicians of our total health spending. And then there's, drugs are about retail drugs, not drugs delivered in the hospitals. Drugs are about 10%. And then there's, nursing homes, post-acute care, and all sorts of other ancillary services. But, just to put in perspective, like if I think a lot of the argument or the discussion around this is, who gets to make a profit in delivering services that people need for healthcare or selling products? Do drug makers get to make a profit? Do insurers get to make a profit? Do doctors get to make a profit? If you want to say we want to replace private insurance with Medicare, with a government program, you're saying, well, essentially insurers shouldn't be able to make profits, but doctors still can, and hospitals still can, and drug makers still can. So, that nuance, I think, is important to think about. What are we actually, what are the policy goals you're trying to achieve?
Well, and in markets with good information flow and competition, the profits get driven down to sort of a minimum level. It gets enough to keep folks in the market. The problem with healthcare is that information flow is usually poor, and it's very opaque, and competition is dwindling. One thing we see here in New Jersey, and it's been a national trend for a long time, is hospitals gobbling up other hospitals, big health systems, including my employer, Rutgers Health, and with RWJ Barnabas, the largest health system, I think they say, in the country. They're partners, they're not merging, it's another story. But those kinds of trends are driving up health insurance costs more than the administrative costs we're talking about, because hospitals are able to demand higher prices from insurers. So this is another example of where I think the strong arm of government could be helpful. There is, of course, antitrust enforcement, which is lengthy and complicated, or government could set prices the way Medicare does, and it would stop hospitals from consolidating for the purpose of driving up revenue from private insurance.
Any other questions from the audience at this point?
We'll bring a mic to you.
You haven't discussed medical records yet. My doctor on Tuesday told me that she used to get copies of test results and things from my secondary doctors, but now, since there's electronic record keeping, she can't get into all there's not just one electronic record now for everybody, there's multiple ones. She doesn't necessarily get anything.
Yeah, this is an area where I think New Jersey is behind the curve. There are other states that have much more higher functioning systems for providers appropriately sharing electronic health records, and there's a lot of promise in that. I think that promise has largely not been met yet. The promise of automation is always, in my view, a little bit oversold. There's been a major shift to electronic medical records, largely driven by the federal government, requiring it, part of the Medicare program, and sometimes subsidizing the adoption of electronic medical records. But this is another example of sort of a halfway government action here, because the government never really imposed standards, a little bit of jargon, of interoperability between these systems. They don't talk to each other very well, and therefore sharing is much harder. There are hundreds of electronic health record vendors out there. There's a few dominant ones that, of course, are very expensive, but it's a system that's not quite there yet. I do think it holds some promise, to turn medical information into analyzable data, because then more can be done to study the impact of interventions and drugs and whatnot, but we're just not there yet.
I think it does touch on a good point, though, that there is this tremendous bureaucratic and administrative burden throughout U.S. healthcare because of the fragmented nature of, providers and insurers, and a mishmash of public and private programs, and all the kind of, everybody has been on the phone with their insurance company or their doctor trying to get some record or some claim to another entity, and it's always a headache, and it is a huge burden. A lot of it falls on patients and their families, who are not compensated for the time and effort they put into resolving this sort of administrative friction. And I think that's one of the things that kind of contributes to the political dynamic here, is that everybody has had these encounters with the healthcare system, people who have been really frustrated with it, and sometimes, in some cases, personally cost them a lot of money, or had a quality problem at a healthcare provider that, shouldn't have happened. Like all those things kind of add up, and, at a certain point, people are driven away from incremental solutions and say, we need something different. And whether that's on the, on the left, Medicare for all, or on the right, we're going to tear out Obamacare root and branch and start from scratch. I do think that's something that, especially as costs have risen, there is a sort of, there's a greater political constituency for, what might have been a few years ago been seen as fringe solutions.
I hold the microphone, so can I ask a question?
All right.
Yes, I've worked for a couple of small companies that on a yearly basis, they struggle to come up with a policy that they can afford and keep the cap on our costs. And it's a huge burden to them. And to have the idea that you could have a standardized go-to, as you said, part private, part federal, part government, and take the burden off of all these small businesses, wouldn't that be one of the greatest incentives you could have to stimulate small business development? And with that said, why don't the Republicans or the current party jump all over that as a huge incentive to stimulate small business, which is what they love to talk about, reducing regulation or stimulating?
Yeah, I think you make an excellent point. The private health insurance market works pretty well for large firms. It's competitive, say firms of 100 or more. The administrative costs are more or less in line. We talk about how so much of the burden of sort of navigating the system is on families. The next group in line for bearing burden is small businesses. They can't afford the HR professional who knows all the regulations and can help the employees. Yet they, they're forced to buy health insurance either by the market or by law, and it's super expensive, as you say. And well, the Affordable Care Act did wonderful things for making sure health insurance was pretty comprehensive. That also drove up the price, especially for businesses that were kind of giving thin coverage before. So it's a real burden and on small businesses. So if it were up to me, the next frontier of sort of expanding the government role would be to help out on that front. So I think you're onto the right thing. Why doesn't the right support that? Because of course they're pro-business. Well, I think they're more anti-government than they are pro-business at times. And so sort of socializing the health insurance for a pretty big sector of the economy is unattractive. And I think a lot of small business owners would feel the same way. They just don't trust government. And it's part of our culture in this country, I think.
One thing worth keeping in mind, when the Affordable Care Act exchanges were first opening, there was a lot of uncertainty around how much employers who were previously providing health insurance would, to what extent they would sort of get out of the game and say, okay, now you can get it on the government market, on these new exchanges. We're just done. It's a hassle. It costs too much. We're going to give you the cash. You go shop for your own plan. And there was, I don't remember the numbers offhand, but I think the Congressional Budget Office was projecting a good number, not a majority by any means, but like a substantial number, several million employers would do that, and it largely didn't happen.
In fact, it went the other way a little bit. I think they projected like a 3% decline in the number of people with employer-sponsored coverage. The estimates were all over the map, but it tells you it didn't happen.
And it shows you that the private employers still see a value in providing health insurance to their workers. Now, that may be because the products that ended up on the Affordable Care Act marketplace weren't as attractive. They often had higher deductibles. They were expensive. But there is, people make the argument that, wouldn't American multinationals want to not have to deal with health insurance when they're competing with European companies that, are often have health care covered by the government? And I think, some people make that argument. I've had executives privately make that argument to me. No one says it publicly, but
Lee Iacocca, I think, too.
Is that right? Okay, interesting. But
It's rare.
But you know, if you look at not what people are saying, but what companies with real money at stake are doing, you know, they had the option to kind of get out of this business in some way when the Affordable Care Act came, and they didn't. So, you know, I think when you think about what the potential effects of a law outlawing private health insurance are, you know, that's just.
There's very deep ideological resistance. And I think, you know, big companies argue that they run efficient systems that meet the needs of their employees, helps them compete in the marketplace, and they're probably right. But you're right about small businesses. It's nothing but an albatross. Yeah.
Do you see any role for properly tax advantage? Do you see a role for properly tax advantage health savings accounts to impose cost reduction in cost and efficiency in the system, as was shown in the experiment in Indiana, the Hoosier program?
So there's a few observations here. One is, you know, again, thinking about international comparisons, the United States has the highest share, both share and absolute amount of cost sharing on the patient compared to other countries, and you saw the cost trends. So it's, you know, at that crude level, it's not imposing the kind of discipline that we would hope for. A couple of other things. One other statistic is that of the, what is it, 3.5 billion? Trillion.
Yeah.
Trillion. We're having trouble with decimal points up here. $3.5 trillion in health spending in this country. About half of that is generated by the 5% sickest people. So no savings account is going to be enough for that 5% that hits that super catastrophic level. And there are ways around that. You can have catastrophic coverage and so forth. One other fact, and pretty well established by the research, is that, yeah, when people have more out-of-pocket healthcare cost exposure, they use less stuff. But they tend to cut back on the helpful stuff as much as they cut back on the unhelpful stuff. So there's some potential health consequences there too. The last point I would make is that it's tremendously unpopular among consumers, maybe because we're so used to having sort of pretty good health insurance coverage. So the Obamacare, particularly for young people and certain other people, has something called the catastrophic option, which is a lot of upfront, you know, several $1,000s out of pocket before you get any benefits. Almost nobody buys it. Almost nobody buys it.
One big barrier to making those types of policies work is that people generally don't have good information about the price or the quality of medical care. And it is, you know, for all the talk about market-driven solutions and using market forces at the sort of individual patient level, patients as consumers, to bring costs down, like outside of some very commodity products, like can you swap in a generic for the brand drug? You know, like if you're buying even like a knee surgery, which is something that's done hundreds of thousands of times, you know, trying to anticipate ahead of time the cost and compare, is hospital A better than hospital B? It's an incredibly complex thing for a consumer to do.
Yeah, and there's only a fraction of healthcare where you would even have the time to do the shopping. You know, obviously you're not going to pull out your app and find the hospital with the best heart attack care when you're having chest pain. There is sort of a movement which is being adopted by a lot of plans now, which is giving more incentives to consumers for specific kinds of things that I think it certainly holds some promise. It's sometimes called reference pricing. So take the knee replacement. The health plan, the employer, government, who's ever running it would, you know, set the price at, say, 80% of what the average is across the market, and after that, it's all out of pocket for you. And then they couple that with information about quality and outcomes, and people, California does this in their state employee plan. Lo and behold, people switch to lower cost providers, and providers lower, the high-cost providers lower their prices because they don't want to lose the market share. So I think there is a role for price discipline. I think it's got to be a little bit more sort of laser surgery than sort of the big sort of health savings account approaches. But there is a bigger role for it.
A couple questions here. And then over there.
I'm wondering if we know anything about the impact of television and print advertising for pharmaceuticals, the impact on health insurance costs. I know of doctors who say that patients come in demanding specific drugs, which are very expensive, when older, tried and true, generically available drugs would be just as good, but people see things advertised and they demand them.
So the U.S. is one of, I believe, 2 countries that allow direct-to-consumer advertising. I think the other one's New Zealand. Yeah. I'm not real familiar with the research here, but it's pretty intuitive that it's going to drive some costs and other things that our health insurance coverage system has done, and also drug marketing directly to providers. We do tend to switch to the more expensive, maybe only marginally better drug pretty fast in this country. So that may be part of the problem. Do you know more than that?
I don't. I mean, just again to put it in context, retail pharmaceutical drugs are only about 10% of total health spending. So it's not a significant
not
driver.
the big problem.
Yeah. It's an interesting question, and but I don't have more than that to.
Yeah, I gave it as an assignment to my students to write papers on the question and to educate myself, and I read the papers and they all concluded something different, so I still don't know the answer.
That's great. Thank you, by the way. This was very interesting and very informative. I'm hearing an echo. Medicare for All has such a powerful, enticing message. But being on Medicare myself, I know there are drawbacks. In fact, there are some doctors that will not take Medicare. There are Part B, as you indicated, very high costs for certain drugs. In fact, I think there's a movement right now for what's called concierge medicine, boutique medicine. In fact, interesting, my nephew does this. He sells it. I'm not a big fan, but I asked him a question. These mostly very wealthy people must be doing this. And he said, well, yes, but mostly Medicare patients. They want to be seen by their doctors. They want to pay ahead of time to assure that they have this quality care. So perhaps we might want to rethink what that means, Medicare for All. It's not a panacea, but it is very attractive. So I think more information should be brought out to the public by those candidates who say they want this, to know what they mean by that.
Well, I certainly agree. One point I would make about the concierge medicine movement, and this is true in virtually every country, that the very well-to-do always have a route to something better. And I think it would be a mistake to close that off, because then you'd lose support for a decent level for the other 98% of us. So, people want to pay more to cut the queue. I would say let them.
The only thing I'd add to that is beyond high-end concierge medicine, there is also a sort of small but growing industry of sort of direct primary care practices where people essentially pay a monthly fee to be part of
Right.
a practice for a doctor who doesn't take insurance, and they get all their primary care in exchange for that monthly fee. Now, it doesn't cover, and they get some discounts on drugs and lab tests. It doesn't cover specialty care, it doesn't cover hospitalization. There are a whole lot of things that it doesn't cover. It's not a substitute for health insurance, but it is a sort of growing industry, and I think, again, that sort of reflects people's frustration with the administrative complexity of the, whether it's private insurance or government insurance. You pay $100, $150 a month to be part of this practice, and then everything primary care is covered. It's a very, I think, appealing option, particularly for people who are uninsured, can't afford a premium, but can afford $100 a month. So, it's just interesting, and, that's obviously not something, I mean, I don't know if that would be prohibited under Medicare for All. It depends on the details of the policy, but it's interesting to see kind of what's, with all the market failures in healthcare, it's kind of one market response to fill at least part of people's needs.
Right.
So.
And I think there is some evidence that those models do offer some financial benefits, as well as certainly more satisfaction, both for the providers and the patients. In fact, there's experimenting with it even with state employees now, and I think it's turning out to be fairly cost effective. Go on.
We had a question up here, I think.
Thank you. When you were talking about potential incremental steps, I'm aware that there are some states, I believe Vermont, New York, and I think there's even a bill in New Jersey that would talk about universal coverage within a state. And I don't know that much about that, but I wondered what your opinion. I'm not inclined to be in favor of that, but I would welcome your opinion about
Sure, there have
that
been
as
a few
incremental
states.
approach.
I'm sorry. Sure. There have been a few states that have tried to move toward essentially state-level single payer, and they run into the same kind of political opposition and the resistance to new taxes and the mistrust that the employers are really going to give us the money back. And so once all the financial modeling is done, they tend to lose support. There's an interesting provision of the Affordable Care Act that anticipated that might be an option, where states can apply basically to repurpose all the federal money and just create a new plan that covers at least as many people without costing the feds more, and then they can come up with any model they want. So the door is open. I think the Trump administration is not encouraging a lot of innovation along those lines. But it could still happen, and there are avenues for it. The same way Massachusetts sort of created the kind of health insurance exchange model that was the model for the Affordable Care Act. I would think that it's not out of the question that a couple of states might do that kind of thing, and that could potentially lead to sort of more acceptability of the model more widely.
It gets really complicated when you have big multi-state employers and self-insured employers who are, exempt from state insurance regulation. And I think they tried it in Vermont, and when they, as you said, when they modeled it out, it lost support because of how much it was going to cost.
That's right.
But it's also, again, kind of technically quite complex to do in a single state, I think.
Yeah, the federal law prohibits states from telling employers, large employers, primarily large employers, what to do with their health benefits, which creates a barrier to state-based plans.
We can take one or more questions. Anyone still have a question?
I can say it out loud. I don't think I need the mic. You said that 10% of U.S. adults are uninsured. Does that include illegal aliens?
Well, of course, nobody has really good numbers on undocumented. There have been some really smart demographers who've made those kinds of estimates, and it's pretty remarkable. Of course, many more of them are uninsured than other sectors of the population, but you wouldn't know it from listening to the news today, but a lot of the undocumented immigrants today are folks who were here legally and overstayed their visas, and lots of them have job-based health insurance. So there's a surprising share of undocumented folks with private health insurance. But they, you know, there's a lot of messiness in the numbers because it's all based on federal surveys, and of course, undocumented folks are less likely to respond. But they're in the numbers, give or take.
I think there was one more question I forgot to answer before.
Yes, about the drug companies. I know that I've read articles where antibiotics, we need to develop new antibiotics, and there's no commercial incentive, but it really could save us from some kind of horrible major flu epidemic or something like that, or vaccinations. But there's no financial motivation for the drug companies to develop these drugs. And it seems like this is a place where government should step in to kind of save us. What do you think?
I think there's actually a bigger problem with antibiotics, and that is they're becoming useless because the bacteria evolve faster than we can come up with new drugs to. And so multiple drug-resistant infections are becoming a really serious problem, and it's partly because of the proliferation and overuse of antibiotics that this resistance has emerged. And you know, I'm certainly not a virologist or actually my wife is, so I can call her up, but the vaccine expert. But I don't think we're going to develop new classes of antibiotics fast enough, even if we were able to do it, to overcome the resistance problem. I think it's going to be a serious problem, public health problem in the coming years. Yeah, Debbie Downer here.
I know I learned an awful lot tonight.
Rhoda, you're not on.
I thought it was on. I said I hate to end on that note, but I know I learned a great deal tonight. I hope all of you did also, and hope to see you again. Thank you.